Well, welcome to this disease state review on community-acquired pneumonia, or also known as CAP. In this session, I'm going to focus on what every healthcare professional needs to know about community-acquired pneumonia, who gets it, basically the epidemiology, what's going wrong, the patho, how it presents, how it's diagnosed, and more importantly, how do you manage it in a way that is clear, clinically relevant, and even help you even prepare for some of your exams. Now, one of the big decision points for managing patients with community-acquired pneumonia is centered around the disposition of the patient. Are you going to treat them as an outpatient environment or the inpatient environment? This not only impacts where the patient is going to be treated, but also what empiric therapy we initiate. All right, guys, I'm Dr. Busti, and thanks for joining me on This Is Why, a show dedicated to helping you understand the why behind the diseases that we all see every day in clinical practice. When you understand the why, the decisions about the how, especially in the acute and also long-term care environments, become faster, safer, and even more consistent. Okay, so one of the things that we're going to do, this is a disease state review, so we're going to hit the background. We'll cover pathophysiology, risk factors, clinical presentation. What is some of the workup that we go through that allows us to get to that diagnosis? And then we'll dive into the treatment strategies, pulling off of some of that information that I'm getting ready to cover first, because it guides us. Again, are we going to be treating this patient in the outpatient environment or the inpatient environment? And then what bugs are we trying to cover, right? And then of course we'll wrap it all up at the end. Okay, so with that, let's jump in a little bit of background information. Now, community-acquired pneumonia is something that develops outside of the hospital setting or within 48 hours of the hospital admission. And the reason that point is made is due to the fact that if patients develop pneumonia inside the hospital, we want to know, well, did that come from, did they bring that in with them and it just finally manifested, so community-acquired pneumonia, or did it actually develop inside the hospital or hospital-acquired pneumonia? It matters because the exposure to the organisms are different, which then would influence the way we would approach the management of this patient. But it is a leading cause of hospitalization. That's not rocket science, but it also contributes to a significant portion of death in the United States in particular. Now, the organisms are heterogeneous depending on the type of pathogen involved and the way the patient presents. That's to be expected. In fact, up to 50% of these cases, you don't really get a good identified pathogen. And that's the reality sometimes. And with that, we need to go through the science of, well, what are the common bugs that we most are likely going to be seeing or causing this, even if we're not seeing it on some of the labs? That guides our empiric therapy as well as their clinical response to the agents that we're using. Okay, let's now dive into the pathophysiology, giving consideration of not only how do people get exposed, okay, and how does it get into the lung, but also then what are some of those organisms. Okay, so respiratory tract infections, like found in community-acquired pneumonia, occur through three main mechanisms. One is the most obvious. We inhale these aerosolized particles and we absorb them into the nasopharyngeal area or down into our lungs. Second is actually by bloodstream. So there's hematogenous spreading from extrapulmonary sites that make their way and get to the lung. And then third is aspiration of oral pharyngeal secretions or contents. This is going to be seen more commonly in our older geriatric patient population where they have more comorbidities. Typically, sometimes we see more risk of obviously strokes, even Parkinson's disease patients with coordination problems and swallowing is relevant. Patients who are bedridden. All of these things can contribute. Now, don't also forget that in even the younger patient population, yes, those things can happen, but periodontal disease, right? The dental caries and the oral pharyngeal microbes are also a risk factor for that. So when we start thinking about some of the common etiologies of community-acquired pneumonia, the majority of these cases are strep pneumo, 70%, okay? That's pretty decent, okay? And so that's important. Now, when we think about other atypical pathogens, that is going to represent 5 to 20% of the cases, but the majority of those are going to be represented or be made up of mycoplasma pneumonia. Now, we're going to dive into breaking down like the common bugs in the outpatient, inpatient, and then if you get into the ICU, and we'll put together a table for you. And again, these tables are available for free download at thisiswhy.health. You can use them for studying, give them to your friends and colleagues. If you're a preceptor, faculty attending, and you want to use these, feel free to use them. What you see here, especially if those of you listening on our podcast channels, this is a summary of the common pathogens. And you'll see on the far left, there's an outpatient perspective of the bacteria that are involved versus the viruses. And then the middle column represents the inpatient, non-ICU environment, and then those who are in the ICU. And you see a common theme, right, of bugs and organisms that are there. You see chlamydia, pneumonia, you have Haemophilus pneumonia, influenza, you have mycoplasma pneumonia, and then of course strep pneumonia. Now, that is consistent when you move across. There are obviously subtle variations. For example, patients who come into the hospital, we need to be giving consideration to Legionella species. Patients that are in the ICU, we need to consider gram-negative bacilli, things like even also Staph aureus, MRSA, and Pseudomonas. And we're going to see that come up again later. In the algorithms, the empiric treatments that we're going to use and start on patients are influenced by the risk factors and their history, where they've been treated, where they recently in the hospital. All of that drives our decisions. Now, when it comes to viruses, you just see respiratory viruses. There's a lot of them that float around in the community. Obviously, we can test depending on where you work, what facility, your lab capabilities, you know, COVID, RSV, influenza, influenza A and B, rhinovirus, parainfluenza virus, all these other viruses that float around in the community that can also facilitate that. Obviously, depending on the age of the patient, their comorbidities, certain viruses don't have treatments or very good treatments. It depends on whether you're inpatient or outpatient, right? So obviously, influenza is one that pops up a lot. It's fairly common. We do have treatments for it. You're going to see later on in this discussion that if patients have concomitant infections, which is possible. I mean, just this past week, I diagnosed patients who tested positive for both strep and influenza. I mean, it just happens. And you would, if you follow the Centaur criteria for strep, you would go, I don't need to test this patient for strep because they don't meet some of the criteria according to the Centaur criteria. So, you know, I mean, just things like that happen, and we need to also keep our mind open to the fact that patients can have concomitant infections, things like influenza, and we want to make sure that we still treat them, especially if they're coming into the hospital, because it's not just the patient that we're treating, we're also treating the patients that are getting exposed around them, including the staff and other healthcare providers. Okay, so that kind of summarizes the main pathogens that we see in this patient population, or that we think about as it relates to the pathophysiology. Now, the other thing that's important to recognize are patients with certain, I don't know, pre-existing conditions, comorbidities. This is a nice table that kind of puts that together. If you have a patient who is a known alcoholic, well, they're going to have more anaerobes risk. Why? Because they're more likely to have altered mental status, pass out, maybe vomit, aspirate, okay? And that's where the oral pharyngeal organisms, even things from our gastrointestinal tract, can also be considered, and that's where oral anaerobes come up. You see Klebsiella pneumonia listed here. This is one of those classic sort of board exam kind of questions in a case where you'll see they'll describe it as current jelly kind of sputum scenarios. But so there'll be, for those of you studying for tests or board exams, you'll see those key words these kind of things that help you to consider the addition of potential empiric therapies that do cover that. Now, there is debate about whether or not just because someone has aspiration pneumonitis that you don't necessarily start them on empiric antibiotics right away. But you have to put that in the context of the patient. What do they look, how well are they doing clinically, and the other comorbidities that may be present. But COPD, when you see hotels, cruise ships, Legionella species, again, classic patterns of association. Why? Because Legionella species live in the water, soil certainly, but water and moist environments, ventilation systems, and it can spread through that ventilation system. And that's where people that are in close contact with each other can then get that more likely. And so hotels, cruises are like that. Cough, whooping cough, where you have a post-tussive kind of vomiting and whooping sound, that's Bordetella pertussis. Active influenza, of course, influenza you need to consider whether it's influenza A and B. Some of the older antiviral agents obviously are not going to cover for both of those pathogens. And then poor dental hygiene, where those anaerobes and the risk of aspiration does slightly go up. All right, I just want to pause here for a moment in this point in the lecture and focus on two fast facts that have clinical relevance to you as provider, but also potentially to the patient. All right, so here's the first fast fact. You just heard me talk about oral flora and the risk of anaerobe bacteria causing pneumonia. You know, this can occur in patients with poor dental hygiene, alcoholics, patients with strokes, changes with altered mental status from other infections, where the change in mental status, where they are at increased risk of that aspiration of both oral and gastric contents into their lungs. Now, those organisms tend to include Peptostreptococcus, Fusobacteria, Bacteroides, okay, Peptococcus, and especially in those patients that are aspirating. Now, alcoholic patients also fit in this criteria for obvious reasons. As they pass out, the alcohol intoxication, as I mentioned before, they vomit, they can't control those secretions, and that results in the aspiration. Obviously, patients with a stroke are at increased risk due to that loss of musculoskeletal control of the oral pharyngeal secretions. Okay, and so this is also similar to our older patients, and I've kind of said this more than once, and I want to drive home this point because I think people tend to forget about it or don't think outside the box all the time. So it's really important that we consider these patient populations and conditions. Now, there's a second fast fact of the organisms that cause pneumonia. Streptococcus pneumonia makes up 70% of the cases, like we said, which is why we have two different pneumococcal vaccines covering a variety of strains and mechanisms for creating active immunity. And those are Prevnar and the Pneumovax vaccines. All right, let's kind of jump back into the lecture, but I felt those two fast facts would be very helpful to you. Okay, now we're going to move on to recognizing some additional risk factors. We've already kind of been alluding to some of these risk factors and comorbidities, but let's just make sure that we hit those main points. All right, so patients who are older, over the age of 65, I think we beat that one up a lot. Chronic comorbidities, COPD, heart failure, stroke, patients with diabetes increase their risk. We're going to see these very things show up in our risk stratification tools like the Pneumonia Severity Index, or also known as the PORT score. They also start showing up in the curve 65. So this is really important why I'm driving these points home. What about opioid use? Well, again, anything that changes the mental status, especially if you have concomitant medications, maybe it's a benzodiazepines, maybe it's other sedating medications, especially in our older patients, that can change their mental status and control of their secretions. Smokers, and then obviously viral respiratory tract infections, okay? Now we're going to move into the next phase, which is getting to some of the ways patients present to us to the hospital. okay? So this is now about the clinical presentation that starts to lead us towards that diagnosis. And again, these are also used in the risk stratification tools that I mentioned a minute ago. Okay, so looking at clinical presentation, evidence of an infection with abrupt onset, something that's outside of the ordinary for these patients, usually fevers, chills. If you end up getting labs, which we'll talk about here in a minute, leukocytosis, these respiratory symptoms include a cough that is productive in nature with increased sputum production. Many of these patients will have dyspnea, sometimes even experience chest pain. Now, there's a lot of stuff going on in the thorax, and patients feel chest pain. They come in a lot of times thinking they're having a heart attack or something else. But when you have inflammation and irritation that especially involves the pleura, that can cause pleuritis, or back in the old days, pleurisy kind of symptoms, and these patients can have anterior chest pain that even radiates to their back. Now, sometimes when we think about the sputum, it can be rust colored. Now, why would it be rusty and colored? Well, remember, the airways have to warm the air. There's a lot of blood flow coming in and out to oxygenate and get rid of metabolic products like CO2. And so with all that blood flow going into the tissue, if you have infection and inflammation, that tissue can bleed and mix with the other mucopurulent stuff that you then cough up. And so people will see blood streaks. That scares them, right? We know that as hemoptysis as a medical term. And so that local irritation can cause bleeding. We see the same things in other infectious disease. Cystitis, bladder infections, hematuria is very common for the same reasons, okay? Now, radiographic imaging can show new or what is considered changing infiltrates, okay? And this can be lobar, segmental, lobar being the various lobes, obviously, of the lung. Now, if you're not sure about how to read an x-ray, or you're not sure what that might look like, I have a lecture on that, on how to read a chest x-ray, but you need to be able to recognize that, because a lot of times what we're doing are portable chest x-rays, which do require a few considerations as you look for that and try to find some of these findings. Okay, now we're going to move to the primary workup and evaluation. We're really getting close to the diagnosis of the patient. Okay, again, these things can also be utilized in our risk stratification tools that help us to determine the degree of severity. And those tools are important because they help us to discern we're going to manage this patient outpatient or inpatient. And I keep driving that point home because I'm leading up to it. All of these things that you're learning or that I'm teaching about will start to all come together, and you'll understand why it matters. Okay, so the first in the workup is considering obviously the vital signs, the pulse, the blood pressure, the respiratory rate, and their overall oxygenation. What is their SaO2 or pulse ox? Now, those variables matter because it also helps you to put the patient, and again, severity, do they start to represent findings consistent with SIRS? That's your systemic inflammatory response, right? And in 2 or more of the SIRS criteria, pulse greater than 90, right, for example, that's one of the SIRS criteria that point to bacteremia and or patients with sepsis. Okay. If they have an O2 sat on room air, pulse ox, that is less than 90%, well, the patient has hypoxia. And if you need to add supplemental oxygen while you're even checking them in at the clinic or in the triage area, whether you're at the outpatient environment or in the emergency department, it doesn't matter, urgent care, it doesn't matter. If the patient O2 stat is less than 90% on room air and they have those other signs and symptoms that we talked about, productive cough, fever, chills, those things, you're seeing a pattern of association that point to the fact that this is most likely or very strongly concerning for pneumonia. Well, once you put a patient on supplemental O2, Many times they need to be admitted to the hospital because, I mean, what are you going to do? Send them home right there on the spot? You don't have oxygen just to give to them and send them out on their way. That's not appropriate, right? That puts them in a higher risk category, okay? Not only in our tools, but also and then what we're going to do in managing them. Next is considering labs. I talked about leukocytosis, and specifically when we're talking about bacterial pneumonia, we want to look at things like your neutrophils, PMNs. CMP, that's your comprehensive metabolic profile. You can also do a basic metabolic profile. The CMP just gives you the liver, enzymes, and calcium as well. But we want to make sure they don't have things like, especially sometimes we see with some of the atypicals, like a hyponatremia or something like that, electrolyte abnormalities that go with it that make the patient overall more complicated, where one comorbidity gets exacerbated for another. What about urine antigen testing? Well, we do consider this depending on the severity of the community-acquired pneumonia. So in severe cases, and you have the capability of doing it, or your geographic area suggests that you do that to guide your therapy, that is something that can be done. I've worked in a lot of different hospitals, and some places don't have the ability to do that. Now, if you're going to start certain empiric regimens, especially if they're more moderate, severe, or they're being admitted to the hospital, you have concerns for MRSA, like I talked about earlier, Pseudomonas, those patients, also sepsis, they start meeting the SIRS criteria, then these patients need blood cultures at baseline. So going back to the CBC up here, we look at leukocytes. Remember, when the leukocytes are over 12,000, or if they're really low, less than 4,000, that also meets the SIRS criteria, okay? So again, you can easily meet the criteria that raises the concern for potential bacteremia and sepsis, that you need to be more aggressive up front. And that's where blood cultures would be obtained before we initiate antibiotic therapy. Why? So that we can actually try to isolate the organism and then tailor our empiric therapy so that we narrow the spectrum and don't expose patients to things that are unnecessary. This is about antimicrobial stewardship. Appropriate use of empiric antibiotics in the right patient with the right comorbidities based on the severity of their condition and their response as we get information back. I work in the emergency department. I don't have that information at the time that I'm initiating care. I don't know what it's going to end up being. So I start certain medications, and those are continued as I admit the patient to the hospital. And then as that information comes to resulting itself, then as we become more aware of it, the inpatient team would appropriately de-escalate or add on therapies based on what I initiated in the emergency part. That is appropriate. That is teamwork. That is what we all need to be doing, and why we need a team effort. Nursing, pharmacy, medicine, all working together for appropriate drug administration and delivery for our patient. And that includes even switching them from IV to PO, which we'll talk about in a little bit. Nasal swabbing for MRSA, okay, especially in patients with risk factors. And then don't forget to test for influenza, especially if you're bringing them in the hospital. And it's the season or the number of cases in your geographic area are on the rise, because we don't want to, one, miss the underlying cause and think it's just bacteria. And number two, we don't want to expose people more to organisms that facilitate, again, the spreading of an illness that then take up healthcare resources and utilization of resources and things like that, okay? Now, imaging, chest x-ray. I brought this up earlier, that if you're not sure how to look at the basics of a chest x-ray, I've got a lecture that helps you go through how to read one of those, specifically portable chest x-rays, because that's the most common thing that we use, unless you're able to get a 2-view with a PA lateral, which is ideal, okay? Now, the type of patterns that we see on abnormal x-ray findings can point us a little bit to what do we think the underlying organism is. So strep pneumo, for example, alveolar or lobar pneumonia. So the right side has 3 lobes, the left side has 2 lobes. Even isolating where that patchy infiltrate is located can help you. Oh, that looks more bacterial in nature. Mycoplasma and chlamydia pneumonia are reticulonodular opacities or more patchy consolidation. Sometimes you can even see that bronchial thickening with mycoplasma. Okay, again, atypical organism. Respiratory viruses, you see commonly ground glass opacities. Unfortunately, I don't have time to go through all of these examples, but I walk through some abnormalities in some of the deep dives that I do on those lectures. Empyema, this is a lung abscess, okay? Many times they evolve over a longer period of time, and then when they finally show up, they look like dense fluid collections, usually in that pleural space, almost like there's a pleural effusion, but again, they tend to be more dense. And then cavitary masses or lesions, again, multilobar involvement. We see this sometimes with other organisms as well. So again, these are not absolutes, they're guides. Many times for board exams, they use these key words that kind of guide you towards the answer that they're looking for, kind of like the Klebsiella and the current jelly kind of sputum scenario. Okay, now, all those things help us to utilize tools like this. Again, these tools are available at thisiswhy.health for free. Okay, if you want to use them for studying or as your own bedside use, so feel free to go there and check it out or share them with your friends and colleagues. But this is the Pneumonia Severity Index score, or also known as the PORT score. It's older, it's been around for a long period of time, but it's really difficult to remember and really difficult to use, even to complete, because you got to have a lot of variables to get that, including an ABG, which we're not going to spend time doing ABGs on every single patient coming in with pneumonia, okay? But the goal of the Pneumonia Severity Index score is, again, to get you down here as the number of points and the influence, the disposition of the patient, okay? Disposition, once you get above 70 in the total number of points, that's where you're in this outpatient environment with maybe close observation and follow-up or a short inpatient hospitalization. Certainly when you go past 91, those patients for sure need to be in. Well, what is the greatest contributor to that? And thinking about the risk factors that I talked about earlier, right up here, age. So when you look at the age of the patient, that's where they start. So if I have a 65-year-old male, their total points are at 65. If I have a 65-year-old female, okay, then I subtract 10 points, I'm at 55. So you can see you're not very far away from 70 at that point. It doesn't take other things very much to get there. They're big points, right? So if you have heart failure, you've had a previous stroke, kidney disease, I mean, you're adding on 10 points right there. So if I have a 65-year-old with a history of heart failure, I'm at 75 right there. Just those two things. I don't need an ABG. I don't even need labs. And so I don't have to have every single variable, or I don't use it clinically this way. Ideally you would, but the goal here is to decide, do I need to admit this patient or can I send them home in a safe way? All right? And so this is one tool that has been used. Now obviously it's complicated, it's hard to remember. If as you use it, it gets easier, but that's where the evolution of the CURB-65 risk stratification tool was used. And CURB is an acronym. 65 is really related to the age. Again, age is a big risk factor. But if they have altered mental status, where that risk of aspiration is going to go up, or their ability to swallow oral antibiotics that I might try to send the patient home on, that's probably not a good idea. Like, hey, I know you're confused, but swallow this pill and drink this water with it. In their, that's not appropriate. So you have confusion, and they're over the age of 65. Well, they're at 2 points. Each one of these counts as a point. So again, this is almost like the 71 to that 90 range where you are considering, yeah, if you're going to go home, we need to make sure that somebody's with you, you have the ability to be followed upon, those kind of stuff, right? So that's the bubble. The 2 is the break point, okay? It's the gray zone. When you see the other variables, you have the uremia, that requires lab, okay? So you have to have at least a basic metabolic profile or point of care chemistry of some sort. And then their respiratory rate. So you see vital signs starting to pop up. You see the confusion pop up. So these are signs and symptoms and some findings that we have on our lab. So you add all those up and you then utilize the bottom part, which is 2 or more. They probably need to be given strong consideration, certainly when they go above 2, for an inpatient admission. Even if it's an OBS admission, okay? Because again, these patients, like I said in the background, have a higher risk of death and even complications, and we don't want to ignore that, okay? All right, so now we're going to move into pulling all of that together. And that's going to lead us to our diagnosis. But inside the diagnosis, we also want to give consideration of the severity, okay? So those things are all the variables that we needed to put into the risk stratification tool for a disposition. But it also points to a severity concern, right? Higher the number, the greater the risk of problems. Okay, so now we're going to dive into these clinical diagnoses. So if you have the signs and symptoms, laboratory findings, radiographic imaging, right, evidence, then that's going to align with it. Most of this is many times a clinical exam looking at a number of variables. Okay, not all of them might completely match up, right? So that's where the clinician's assessment and the exam and for the diagnosis becomes very important, okay? Next is consideration of the severity designation. And what we really get concerned about is really when we get in that severe community-acquired pneumonia, okay? And the definition of that is that you have at least one major or 3 or more minor criteria. And again, I put together a table for you. Again, if you want that, this is why.health that's available. But there's a major criteria, so septic shock. So these patients meet criteria for sepsis. They have 2 or more of the SIRS criteria, but they also are not maintaining their blood pressure. Usually MAPs are not going to be greater than 65. And these patients need vasopressors. That's not good, right? We're having to support them. The bacteremia is causing an abnormal immunologic response that is causing leaking and vasodilation and hypoperfusion of the tissue. Respiratory failure requiring mechanical ventilation. So remember that pulse ox showing hypoxia, but if they can't correct that with supplemental oxygen, or they're tachypnic so much that they're fatiguing with the breathing, then you can try BiPAP as long as they're able to follow commands, they're not vomiting, you don't want to put a mask on somebody who's vomiting or altered, then you may have to protect that airway, and the only way you can do that is do endotracheal intubation and put them on a mechanical ventilator. Those patients are going to the ICU, clearly. So that makes them fall into that severe community-acquired pneumonia bucket. Remember, you got 3 or more of the minor criteria. Respiratory rate greater than 30, so they're tachypnic, okay? Now I got to keep in mind, this is more of adults. Pediatric patients can sometimes breathe that fast. Remember, their pulse is higher, their respiratory rate is faster earlier in life, and then it changes as they age. Multilobar involvement, so you have multilobar pneumonia. Those patients are at clearly higher risk, most likely need to be admitted to the hospital. They're confused. Again, they can't take oral antibiotics. Their risk for aspiration goes up. They have thrombocytopenia. They're showing signs of lab abnormalities where they even have multi-organ involvement, okay, where then the sepsis and DIC, these kind of things, they're raising red flags. They can't maintain their temperature. And then they're obviously hypotensive. Again, kind of pointing back up here, are they going to be put on vasopressors at some point, plus or minus even adding steroids, even though we have to be very careful with the use of those in this patient population. Okay, now we're going to move into the treatment. And with the treatment, I want to hit on some of their goals, some of the basic considerations, general considerations as we kind of wrap our minds around the patient. What are we going to use? What are we going to initiate as empiric therapy? You need to keep in mind that what I'm also going to do is walk us through the subgroups of patients based on, are we treating them as an outpatient versus inpatient, okay? And it matters because no matter where you practice, because if I have a patient who has a short hospitalization and I discharge them home, they're going to continue on therapy. So if I do a 23-hour observation, because they were kind of in that gray zone, well, then I'm going to send them home on an antibiotic. They need follow-up, okay? So that's why it's important whether you practice in the inpatient or the outpatient environment, it's good to understand what your patient has gone through as they maneuver through the system. That's good healthcare where there's continuity between the two phases. And I think many times we, especially nowadays, seem to miss that where everybody's seems to be in a bucket, right? I only do outpatient, I only do inpatient, and the patient's stuck in the middle, moving between the two, and the providers are not talking to each other. That's not right. So I want to make sure that you guys understand the proper treatments, but you see the big picture, okay? All right. So treatment goals, not rocket science. We obviously want to eradicate the infection and prevent hospitalization, reinfection, but we also want to improve and reduce the risk of mortality. We also want to apply and implement good antimicrobial stewardship practices. I cannot stress that enough. The amount of resistance that has evolved over the past several decades is due to we don't know what we're treating, we'll just give you an antibiotic. I mean, I've had patients literally come into the emergency department who have paperwork saying that you have acute viral syndrome, and they were sent home on antibiotics. That makes no sense, okay? That means that the provider wasn't even thinking and just the patient wanted an antibiotic even for a viral infection. That's not appropriate. So, and it's not appropriate for me, even in the inpatient side or in the emergency department, to just use every broad spectrum antibiotic possible, anti-pseudomonal drugs, MRSA drugs, things like linezolid. It's not appropriate. Unless the patient has risk factors, then it is. Okay? So I need to participate in that. You would need to participate in that. We all need to participate in that. Our colleagues in pharmacy are looking at these things. We need to work together as a team to help each other out, checks and balances, making sure it's appropriate. Okay, I beat that. I beat that to a pulp because it's important, guys, because we're going to run out of options, and then we create these super bugs, right? So we need to think about what are the most likely organisms. Where is their treatment setting, inpatient, outpatient? What are their comorbidities, including even things like HIV and patients with neutropenia, where their immune system may not be sufficient to fight for them. We need to make sure that the treatments that we use in the empiric therapies have that are bactericidal in nature. They don't rely on a functioning immune system. Bacteriostatic drugs require a functioning immune system. Okay, so what we choose empirically should fall into bactericidal options, right? And then, of course, consider organisms that the chosen regimens may not cover, okay? Especially if the patient gets admitted and they start to get worse. We are obviously potentially missing something, okay? Now, the next couple images and tables, again, are available at thisiswhy.health for you. But what I've done for you is broken up the outpatient treatment regimens based on the clinical scenario. And then what are those regimens and what do they look like? The doses, the frequency of administration, duration for those of you that need it. Even though for like board exams, they're not used. I have never taken a board exam, and I've taken a lot of them, being a nurse, a pharmacist, and a physician. There's maybe 1 or 2 questions I've ever received in all of those exams where I've had a dose, okay, where it was specific to a condition or issue. Most of the time you're picking the right drug for the right situation. Maybe it's a duration or a frequency of administration, but very rarely do we need that. But it's still important that you understand how to treat that. And so I put those together for you. So in this example here, these are outpatients with no major comorbidities or risk factors for MRSA or Pseudomonas. So you can use things like amoxicillin, doxycycline, basic macrolides in isolation. So singular agent, not concomitant or combination therapy. Once those patients start to have comorbidities, okay, things like heart disease, lung disease, kidney disease, malignancy, diabetes, on and on and on that we've been talking about, then we want to consider the coverage of both strep pneumo, those Haemophilus influenza, but also the atypicals. Okay? Now, beta-lactam antibiotics are not covering those atypicals. Atypicals are intracellular organisms, and you need good intracellular penetration by the drug. What a drug does in a petri dish is not the same thing as what it does in a real human body. So you've got to deliver the drug to the right location, the right concentrations to achieve the desired therapeutic effect. And so drugs like macrolides will get inside of the cell at higher concentrations. Fluoroquinolone antibiotics will cover atypical organisms because of their intracellular penetration. And so that's where you see with comorbidities the addition of macrolides, doxycycline, being added to the beta-lactam, because the beta-lactams are not going to be able to cover those atypicals by themselves. Okay, so these patients are sicker. You think about your PORT score, Pneumonia Severity Index score, and you think about the curve 65, these comorbidities start to raise the concerns, right? Now you see gemifloxacin listed here. Gemifloxacin is no longer available in the United States in particular, but levofloxacin, moxifloxacin is. So if you're outside the United States, you might still have access to some of those. Just keep in mind that these things come and go. Always obviously practice within the guidelines as you have access to resources. And then I move into the tables that are for the inpatient environment based on their severity and whether or not they have risk for MRSA or Pseudomonas, because you want to make sure that your drugs, your empiric therapy, has anti-pseudomonal coverage or has MRSA coverage, okay? And so in this particular group, what you see is a lot of times many of the same drugs that we used in the patients who have outpatient but maybe have some comorbidities. We see levofloxacin, moxifloxacin as options. We see the macrolides as options added to a beta-lactam as well. Now, when we start to get into those more severe inpatient cases that do have some concerns for Pseudomonas, then these patients need to, these are severe without, I apologize, severe without MRSA. Again, this is where you might see a beta-lactam plus a fluoroquinolone, although that's probably less desirable if possible. In most cases, we try to avoid that simply because of the amount of microbes that we're going to be messing up. But if you're going to add on and you're concerned about MRSA, such as patients have had previous isolates on their sputum cultures, they've had blood cultures and they've been previously admitted, they were in the hospital in the last 90 days, these things put them at greater risk for these organisms. Well, then you need for MRSA, vancomycin and linezolid. Number 2, for Pseudomonas, you need anti-pseudomonal coverage, so amoxicillin's not going to do that, augmentin's not going to do that, ampicillin's not going to do that. You need drugs like piperacillin, cefepime, ceftazidime, moving on to imipenem, meropenem, H-trianem. These are all for your gram-negatives that would have anti-pseudomonal properties. Now, one of the things that I tried to put together is an algorithm for you. Again, it's just the same information as those tables, but it walks you through a decision tree. All right, so if I'm one of these algorithms is the outpatient, so if you have comorbidities and without MRSA and Pseudomonas, then you would initiate these agents. Again, this algorithm doesn't necessarily put the dose and the frequency, and that's why I put both the tables along with this algorithm there for you. But it's just a replication of the information. Again, these tools are available for download for you if you like to look at it in a more algorithmic decision-making pathway. But again, it doesn't outline some of the details. So the two together work the best, especially if you don't know some of the doses, frequencies, and you're still new to some of that. Now, moving on to a couple other treatment scenarios. What about steroids? I see them used a lot out in patients. Is it appropriate? Well, it depends. Okay, it's not routinely recommended. However, if the patients have, for example, other comorbidities, that would be a reason. Maybe they have asthma and they're wheezing, okay? COPD. But what if they're septic? So there is a scenario where patients are not responding to IV resuscitation with IV fluids and vasopressors. They might need that, especially if they've been on chronic steroids where they have a hypothalamus adrenal suppression, and they have basically adrenal insufficiency, and they now are sick and they need stress dose steroids, and typically that's prednisone equivalents of usually 7.5 milligrams or greater, certainly once you get 10 milligrams or more. There is some literature that says you can go down to 5, but so that 5 to 10 milligrams per day of prednisone equivalent, or prednisone itself, puts you at increased risk for adrenal insufficiency, where during a stressful response like this with infection, the patient needs supplemental steroid use, especially if they're having evidence of shock. All right, now I'd like to transition to a few clinical knowledge pearls, things where I want to unique special patient populations, special factors to consider. I've already touched a little bit on this, but it'll drive it home. These are the pearls that you want to have in your back pocket and not miss, okay? So the first is considering old terminology, HCAP. I just want to throw that out there. It's no longer used. It's no longer recommended. There was some crossover with patients who had basically risk factors for drug-resistant pathogens. I just really wanted to make sure that people are aware of that term. Things evolve as we study. We write guidelines. They change. We try to simplify things to make them more clinician user-friendly, but healthcare associated pneumonia, you think about patients like coming from a long-term healthcare facility, dialysis centers, nursing homes, these kind of environments where those patients are at greater risk of having exposure to multi-drug resistant organisms, and so instead what we want to do is have those risk factors be utilized to help us to determine the specific coverage. And that's where, again, the understanding those comorbidities that I talked about earlier and the bugs that are there, that helps to drive your main decisions. Now, what about anaerobe coverage? I mentioned this earlier. If you're aspirating, maybe from altered mental status because of a stroke, or you have periodontal disease, all these things, and you start to show manifestations of pneumonitis, it's really not recommended that all patients empirically get started on anaerobe coverage just because they aspirated. But you do need to keep in mind and watch them because they should have some symptomatic resolution within 1 to 2 days of the aspiration. So just keep that in mind. Obviously, it's patient specific based on your exam, the providers who are managing those patients. But if there was significant aspiration, maybe you might want to consider it, especially if they have hypoxia, significant respiratory compromise. Again, it's not an absolute, all right? But again, this is about antimicrobial stewardship. Think about it, okay? Lung abscesses, all right? So these are circumscribed purulent collections, like I mentioned, in the lungs. They can be dense. They can show up in that pleural space. But it's basically empyema is another term, right? Basically purulent fluid in that pleural space. And these patients can have an indolent course that occurs over weeks to months. Many times they were sick with something before, and then they kind of got better, and then they get worse again. And that's basically tissue that's dying. That pus is necrotic tissue. I mentioned concurrent influenza, especially if it's in the time frame of the year where the number of cases are high, or maybe some of your workup and radiographic imaging isn't clear, okay? Maybe you test them positive, they're coming with pneumonia, but the incidence or prevalence that's going on of the influenza is high. Check it, because you're not just treating the patient, you're protecting other people in the hospital who are also sick. And should you treat both? Of course. I mean, again, I've seen people say, oh, well, it's been beyond 48 hours, the patient doesn't need antiviral therapy. That is not true. Okay? That is a study in otherwise normal, healthy individuals in the outpatient environment. If someone's coming in the hospital and they're sick and they're getting progressively worse, you want to give consideration of treatment. And so oseltamivir, baloxavir would be your standard antiviral therapy that would be added to antimicrobial therapies in patients, especially who are fairly sick, moderate to severe cases. Now, what about IV to PO transition? Again, this is part of that, once a patient is more alert, their mental status is improved, or they're not vomiting from their illness, because even with the virus, you can get gastroenteritis, then we want to use the gut, especially if it's working and they're hemodynamically stable. Why do we want them to be hemodynamically stable? Because you need good blood perfusion to the GI tract to absorb it for bioavailability and adequate concentrations in the body, okay? So if they're able to use the gut and they got good perfusion and there's nothing interfering with it, then you need to really give that consideration. It's not just appropriate, reduces IVs needs, which are risk factors for infection, but it also prepares them for discharge, which then means as the outpatient, they're going to follow up, okay? So if possible, you do want to give consideration of, okay, well, what IV treatments am I using? If I have need for MRSA coverage or Pseudomonas coverage, well, there's only a few oral options available, right? So your linezolid, tadalafil, or basically the options that you have for that equivalent to for vancomycin, right? They're not equivalent, but I'm talking about coverage. If you need anti-Pseudomonas coverage, well, you can't send them, if they were on Zosyn, you can't send them home on Augmentin. It doesn't work that way. You got to send them home on a oral treatment that has anti-Pseudomonas coverage, things like levofloxacin, and then it's even at appropriate doses of the fluoroquinolone. And so it's important that when you're considering the switching of the IV to PO, that you consider the drug class, and the organisms that you're trying to cover. Now, what about duration? You don't probably want to do less than 5 days here, unless they have some, there's some reason, maybe you got information back that would suggest, but you want these patients to be clinically stable and you want to not create resistance. So what is clinically stable? Well, they shouldn't still be febrile, okay? They shouldn't be hypotensive. Again, this is more of adult. They should not be tachycardic. Again, the pulse over 100. They're not tachypnic, okay? And their O2 sat should be greater than 90% en room air, or obviously if they have a baseline reason for oxygen like COPD or something, they're chronically wear oxygen, fine, but that their requirement is back to their baseline. 7 days is typically recommended, especially if there is evidence of MRSA or Pseudomonas. So your organisms do influence that at some level, okay? Now, special populations. Our geriatric patient population has more comorbidities as the aging population stays alive longer. That puts them at greater risk for severity. It puts them at greater risk for changes in mental status and drug interactions and all these things. And that matters with things like linezolid, tadalafil. It matters with fluoroquinolone antibiotics, which can also cause some change in mental status sometimes in patients. So we want to be careful about the drugs that we use in these patients and consider their other comorbidities so that we don't exacerbate them. For example, fluoroquinolones also can cause QT prolongation. Well, who's going to have that? Well, a patient with underlying cardiovascular disease, structural heart disease, and maybe they're on antiarrhythmics, maybe they're on amiodarone. Well, when you start adding multiple drugs that have similar effects or adverse effects, that effect can start to compound and become additive and become more concerning for that patient population. What about HIV? Again, if they don't have a functioning immune system, their viral load is out of control, their CD4 counts are low, that patient doesn't have a functioning immune system dependable enough, we want to make sure we're giving bactericidal agents. But you also need to keep in mind things like PCP, right? Or PJP. PCP is the old, sorry, I grew up on that label. It obviously has changed to pneumocystis jirovecii pneumonia, but you got to keep that in mind because there's certain treatments for, use of Bactrim and things like that that would be different. So you got to is the patient responding like they're supposed to? So HIV patients are just as equally at risk, if sometimes not more, depending on how well controlled they are, to outpatient or community-acquired pneumonia, okay? So we're going to use the same principles as non-HIV patients. Now, given that some HIV patients may be at increased risk of tuberculosis or, exposure to it, and depending on lifestyle risk factors, if you end up using a respiratory fluoroquinolone, those can have some activity against Mycobacterium tuberculosis. If that patient has active disease, obviously they should be on antimycobacterial agents for TB. You don't want to use respiratory fluoroquinolones as monotherapy in these patients because of the risk of resistance in those patients. So just keep that, again, in the back of their mind. I like to integrate a little bit of evidence. I talked a minute ago about duration of therapy, that 5 days, 7 days. There's a lot of things going on in the literature that help guide us. This one was a study looking at the efficacy of a short course antibiotics. Because everybody says like, oh, it's just 7 days. Everything's 7 days. Well, no, it's not. Yes, a lot of regimens do fit in that. We've seen that, but it doesn't mean you don't have to always do that. So we talk about the 5 days versus 7 days. And so in this particular study, for example, they basically showed that a short course treatment had fewer adverse events and a lower mortality than long course. So we don't want to push people to 10 days unless there's some reason for it. And just because they come in with some ongoing lingering symptoms, do they really need an antibiotic? Okay, what are we really treating? Again, this goes back to that antimicrobial stewardship that we need to give consideration. Okay, guys, let's now take a moment to wrap this up and hit the high points. All right, pathophysiology, remember, the respiratory tract has got a lot of oral pharyngeal area. We breathe in a lot of things. Strep pneumo, 70% of cases. Outside of that, we have atypical organisms, mycoplasma, and then, of course, respiratory viruses. Clinical presentation, it's an acute change in their clinical condition. Onset of illness, fever, chills, dyspnea, shortness of breath, usually with a productive cough. Classic findings, x-rays. We're usually going to see infiltrates, especially with bacterial causes. And then that all leads us to use our risk stratification or prediction rules for determining the disposition. Pneumonia Severity Index, also known as the Port score, Curb 65 are classic examples of those tools. And then as we use them and drive them, remember, it's helping us to pick the right empiric antibiotics. Are we treating this patient as an outpatient, or are we admitting them to the hospital? And if we're admitting them to the hospital, what is their severity? And we covered some of those risk factors that put patients at higher risk of complications, but also considering the exposures of things like MRSA and Pseudomonas so that our empiric coverage includes that or needs to be added on. All right, guys, well, I hope you found this to be helpful. I would really appreciate it if you haven't already to subscribe to my YouTube channel, give us a like, share this with friends, colleagues, people that, especially if you're learning this for the first time or you need a good refresher, all right, you're in class, residencies, training, feel free to share it, please. And give us feedback, welcome that. If you want those downloads, those can be obtained, and the link to that is in the description for the video at thisiswhy.health, so check it out. Again, free for anybody that is interested and wants to use those, feel free to share them, okay? And then check out other diseases and drug class reviews that I put out, including medical rounds topics, other things, even medical terminology if you're still learning certain things. All of those things are available at the YouTube channel. Thanks so much for joining. We'll see you next time.